Okay, welcome. Can you open this mentimeter.com, Mentimeter, in your phones and enter that number 23602559, menti.com, 23602559. So I'm not sure, some of you might have been in my last lecture. I did on quality improvement. Anybody vaguely remembers? Okay. So this is not exactly, at the bedside, patient to physician, but it's looking at the overall health system of how we function, whether the way we function is safe or not. So this is a separate field in itself now, patient safety, and taken very seriously by health systems across the world. Increasingly, even in India, you will see that with the advent of NABH and other accreditations which have come. NABH is the first one, but now there are others also. Patient safety is taken very seriously, and increasingly there are more and more requirements on the hospitals, on the physicians, nurses, for us to make sure what we do is safe for the patients. Okay, so this is just a introduction. Hopefully, I'll do another session in the MAC conference. So might sound a bit like theory, but I think it's quite relevant. Hopefully, you'll get introduced to this concept. So we'll try to understand what is patient safety, reasons for unsafe practices, then theories to understand patient safety, safety culture, and error reporting. This is just one bit of it. There's much more in this field. Okay, let's start with the case scenario. Ward has a shortage of staff. Rohini is a new nurse and she volunteers to work on her off days. And Annabelle is the other nurse who's asking for help to give diabetes medications for patient Sanjeev Mishra. Rohini agrees and starts to work. While she is taking the medicine, she is interrupted by the dietitian with some doubts. Rohini is not aware that there's another person called Sanjeev Mishra in the ward. And she gives medications for wrong patients, even though procedure requires her to cross-check date of birth and hospital number. Patient develops hypoglycemia. Can happen. Can happen with us. Have we all done some error like this? May not be exactly like this, but like this. A wrong hospital sticker in the prescription. Like how frequently in a month? Wrong hospital number in the prescription. Let's have some show of hands. Me. Happens so frequently. Yeah. But somehow somebody will pick it up, either patient or pharmacist, or at some level it will get picked up. Okay, so this is the scenario. Can you write in your Menti if what is the reason for this safety incident? Are you able to type? Hopefully it will come. Working off-duty hours, burden of work, interruptions. Shortage of staff, working on off days, interruption, shortage of time, work on off days, not following the systems in place to prevent this. For example, stickers with numbers, interruptions, no cross-checking. Name alert could have been prevented. She was not given correct directive in this case, explain extra clearly. So is it as simple as blaming that lady, you did the wrong thing? Not, isn't it? Can you catch Rohini and say, you, no matter what the system is, you are the reason for the error? Please be interactive, giving some response. Yeah. Is it as simple? Is it just the Finally, you're the one who gave it. You should have checked. You're suspended. How does it sound? Outrageous? Okay. All right. So patient safety has evolved over time. Now it's considered a discipline in the healthcare sector that applies safety science methods towards the goal of achieving a trustworthy system of healthcare delivery. It minimizes the incidents and impact of and maximizes recovery from adverse events. There are a lot of definitions. So to understand about this, a lot of people have come up with various models. These are the common ways in which the whole thing of patient safety is approached. Okay, first the structure, process, outcome model. Second one is maybe a bit more familiar for all of you, the Swiss cheese model. Anybody familiar? Swiss cheese model? Heard of it? Seen the picture? John's raising his hands. Sometimes when he even reads some non-fiction books, extra like a checklist manifesto, it might have come. Okay, that's the second one. The reason is the person, his name is James Reason. That's why it's called Reason Swiss cheese model. Then Rasmussen's model of system migration and error analysis. We'll just briefly see what each of these model explains. So structure is in this model that in this case that we saw, the ward is a structure, the physical and organizational sources. Imagine the ward that you work in, I ward. Just look at how the structures, how the beds are placed, where the nursing station is, outer corridor, inner corridor, how you enter, how the patients are taken through the narrow pathways, then the lift and the first floor, second floor. Just imagine the whole thing. All that is structure. Okay. Processes, what happens? The duties, what is expected of the doctor, how the intern is expected to give the prescription, what he's supposed to sign, what he's supposed to, enter in the online prescription system, etc. So the various activities. In general, it's about policies. So structure and policy together will finally, lead to outcome. Outcome may be mortality, morbidity, number of days in the hospital, etc. Okay, so changes in structure, the way the structure is organized, the way process is organized will affect the outcome. So by manipulating the structure and the process, we may be able to change the outcome. So wherever you are, this is what it's going to be. You might go to a smaller hospital of your own. Let's say you set up a 40-bedded, clinic in your hometown. Let's say you're from Tanjavur, you go back to Tanjavur and set up a clinic 40-bedded. You're going to put in structures, you're going to put in processes, and that will affect the outcome. So that is what this is done by a person called Donna Bedian, and this helps us understand that by working on the process and by working on the structure, we may be able to work on the outcome. Specifically here, it's about safety outcomes. Okay. Now this is Reason Swiss cheese model. The Swiss cheese will suppose to have perforations like this. So there are multiple layers, successive layers of defenses in a system, in the healthcare system, in order to avoid safety incidents. So let's say you give a wrong prescription, okay, online prescription, you prescribe, tell me a common, recently somebody prescribed Vincristin instead of something else, okay, a simple drug, somebody prescribed Vincristin. Vincristin is a nice drug to take. I mean, of course, nice drug for somebody who has, malignancy, needs it. And just imagine giving it for somebody who has an infection. Wipe out all the, immunity, and then that's going to be a disaster. Do you think such errors happen in the hospital? Unfortunately, it happens. Okay. And then the letters go and the explanations and events and all that. It's obviously we need to make sure that these errors don't happen. Now, a lot of times most of the times the pharmacist will, screen it and it will be picked up. So the error which you do in prescription is a prescription error which is picked up by the pharmacist. Let's say pharmacist also comes to the ward. The nurses are very alert. In fact, most of the letters and alerts will come from nurses. The sentinel events entry, ADR events, mostly written by nurses and not by doctors. A small percentage will be by doctors, and usually will be picked up. You give a intern writes a wrong dose, nurses will call and say, "Well, this is not the correct dose. Please give it." So you have multiple layers of defenses. So here, for the example which I gave you, is pharmacist one defense, nurses another defense. Finally, the alert patient might say, "Sorry, I'm not a hypertensive. Don't give me the antihypertensive drug." Okay. Now, just imagine if the pharmacist is not alert, the nurses is not alert, and the patient is not alert. All these holes will align, and that's when big mistakes happen. Okay, that's the Swiss cheese model, and that will happen now and then. When all these holes align, accident happens. Okay, so the whole medical system in general has these multiple layers. In fact, it does prevent a lot of accidents, but a lot of near miss events happen. And very often these are very hard to track, near miss, because let's say the nurse notes that you've given a wrong prescription. Will she report it? She won't usually. It's a near miss. Nothing happens. Let's go on and carry on. But then for every 10 near miss, there might be one big accident that will happen. Okay. So understand this. This is one way to understand the whole concept of patient safety. Then there is, don't get scared by seeing this complex graph. Just look at those things in the boxes. The legal, and there's illegal normal, and there's illegal. So in general, we'll start with legal, and then we will extend our activities to a bit of a illegal normal, and then it'll go on to a illegal. Okay, let's say the speed limit is 30 kilometers per hour, and how many people will actually go in 30 kilometers per hour? How many will go in 90? Not many will go 90, isn't it? How many will go at 40? A lot. Yeah. So we've just gone beyond this. Like, it's okay. It's not bad at all. It's a bit of a, I have a lecture to take. I need to rush. So that's how it works. How many of you write in your prescription, write the name, hospital number, unit, sign with employment number, and also write the medical thing number, the NMC number. How many of you write mostly name, hospital number instead of name and hospital number? Show of hands when you write a prescription. One. I do write frequently, saving time. So that is a bit of a illegal normal. It's okay, not bad. We need to save time. I have 40 patients. So in general, that's how people move on. But what has been found is actually the illegals are more common in places where the illegal normals are also more. Did you understand? If the illegal normals are more, the illegals will be much more. So if the predominance is legal, the illegal will be less likely. Okay. Anyways, so understand that's how in general most systems people will work. They'll move from the legal to illegal normal to illegal. And we need to constantly have some kind of checks to prevent that more, from the system migration, moving from legal to illegal. Okay. So here it is, all those, if you see this line, all the rules, protocols, in-depth defenses, barriers will prevent people from moving to this, but then people will break that. One or two people will break it due to individual variation, and we will just overlook. It's okay, 40 is okay when there is a speed limit is 30. We won't. We'll be upset if somebody goes at 90, but we won't be upset if it's 40. We'll say it's all right. Isn't it? Okay. Now, So we can actually classify these errors into bad outcomes versus, um, you know, as opposed to an error. Would you write what you think this is? Patient who has never received penicillin develops allergic reaction to ceftriaxone. Adverse event, bad outcome, error, near miss event. Not many of us. Okay, so I think most of you are right. So this is an adverse event. I'll give another example. Patient develops severe ARDS due to scrub typhus, goes to ICU, gets maximal treatment. Despite best despite best treatment, patient does not survive. What is that? Adverse event, bad outcome, error, near miss event. Bad outcome. Okay, that's a bad outcome. We done the best. Okay. Patient is known to have allergy to penicillin, and the doctor prescribes amoxicillin. Error. Okay, that's an error. Okay. Patient is prescribed amoxicillin by doctor. Pharmacist is alert, and he calls the doctor and says, "You prescribe this. Patient has allergy to penicillin," and the doctor changes and he gives the right drug. Near miss event. Okay, so in general, the systems are made in such a way that the near miss events are more, and the errors and adverse events are less. Okay, because we can't avoid it entirely, but we can make sure that everything is caught up in this level. Okay. We can also classify human behavior as human error, at-risk behavior, and reckless behavior. What is acceptable? Okay, what is not acceptable? Reckless behavior. Okay, at-risk behavior is also not acceptable. For example, if we don't write a proper prescription despite being told, that's at-risk behavior. If we keep speed limit is 30, you keep going at 50, that's reckless or at risk. You can go this way. I think it's more of a at risk. 90 is reckless. Okay, so what should we do for reckless behavior in terms of in the ward and the system? Can we put system level changes to avoid reckless behavior? We should talk to them. They need to be dealt with, isn't it? I think this is not very common. In general, there'll be there'll be a 1 out of 100 person who might actually exhibit this, and this person has to be dealt with by the leadership, okay, in the unit or department or whatever. So this actually helps us but human error. Let's say you are writing a prescription and you didn't have any intention to write a wrong prescription, but by mistake you write a wrong dose. Let's say instead of 100 milligram, you write 50 milligram. That's an error, isn't it? That can happen. So what approach should we take to such kind of errors? We can make system level changes to make sure that such errors don't happen. Okay. Should we catch and punish them? So overall, worldwide, this approach to errors have changed. So there was a landmark one article, or it's a document which came in the US called "To Err is Human." Okay, so previously somebody does a mistake, catch them and give them some thrashing and say, don't do this next time, and you expected them not to do it. Okay, that approach is changed worldwide in general, but that approach is not something which we should take in because to err is human. Things can happen in a system like this. But of course, that's not the same as reckless behavior and also at-risk behavior. Errors do happen. Giving you type cycloserine for MDR-TB patient, and in your thing you type cyclosporin appears. You click cyclosporin and you prescribe. Human error, at-risk behavior, reckless behavior. What is it? All the examples I'm quoting are real-life examples. Okay. Cyclosporin or cycloserine? Cyclosporin for somebody who needs cycloserine. It's an error, isn't it? It's an error. Now we can actually make some system level changes to make sure that this don't happen. Okay. But this error can happen, and the approach will not be more of a punishment and expect that to change outcomes. Will not. Then there is this concept of active failures versus latent conditions. So active failures are those errors and violations that have an immediate adverse effects, usually occur on the front line. Okay, giving, let's say, giving a wrong drug. Okay, I'm just thinking of any recent example. There are so many. Anybody can think of an example? Immediate error. You give, let's say, you give an antihypertensive patient for a drug for somebody who's not antihypertensive because the drugs got mixed up or you mixed up the name. Okay, that's a active failure. Then there are latent conditions. These are decisions or actions, the damaging consequences of which may lie dormant for a long time, only becoming evident when they combine with some other, triggering factor to create an adverse event. They set up the conditions for active failure. Okay, for example, if you make a duty in such a way that the example that we saw, somebody is overworked and sleepy and constantly put on in a place where errors are quite serious, that's a latent condition. Okay, or if there is a system in which there are no checks and balances, for example, a prescribing system in which it's easy to do a error, that is a latent condition for an active failure. So in your system, when you look at wherever you're working, you need to see whether are you setting up any latent condition for an active failure. Okay. Then there is this concept of culture of safety. Let's see this case scenario before we look into that. So this Mr. Y, 56-year-old man, fatigue and anemia, admitted in a semi-private room, bed 1. The bed is close to the patient room door. After the rounds, the registrar is asking for a cross match. In the meantime, patient wanted the bed 2 on the window side. Nurse also says, okay, so patient is moved to bedside. Busy evening, and the nurse forgets to update the bed management system. The registrar told the intern, have you done the cross match? And he goes, takes the cross match from a new patient who has come, patient Z. He's got Parkinson's disease, and the attendants have placed him in the the other bed. The name is not changed. Intern arrives and looks for the patient, notes name on the bedside, takes blood for cross match. In the meantime, nurse remembers, she changes the details, the bed manager changes it. Blood arrives, cross match is done for other patients. Blood is given for the new patient. Patient develops severe transfusion reaction. How should this be addressed in a culture of safety? So how can the patient safety culture be assessed on this inpatient unit? And how can we learn from this? So culture of safety is basically shared values and beliefs that interact with an organization's structures and control systems to produce behavioral norms. In general, this is how things work here. That is the culture. Okay. And culture is the real thing. There are systems in which the culture will be better. There are systems in which the culture will not be better. This is a reality. Okay, we can't not face this reality. There are other ways of defining it: norms, practices, values, and beliefs the people working in a given unit, department, hospital, or hospital system. That can also be said about culture of safety. So in the US, they set up one agency for health research and quality. I think nearly about 25 years back. They had these goals: recognition of high risk activities to obtain reliable operations, presence of blame-free environment in reporting errors on EMSs, practicing collaboratively to identify solutions to safety problems, and also leadership commitment to address patient safety norms. So these were the goals, and this was set up, and this is the definition which they came up with: the product of individual and group values, attitudes, perceptions, competencies, and patterns of behavior that determine the commitment to and the style and proficiency of an organization's health and safety management. Now, this all sounds too thing for somebody. We are just bothered about values. Sodium 120, let's correct it. This is a bit abstract, but these are all as important as what we do for each patient. Okay. So there can be a weak safety culture versus a strong safety culture. Now, would you write and tell me how would you describe a strong safety culture? What would you expect? What are the characteristics of a strong safety culture? Think of your department, unit, ward, wherever you worked, and how would you describe a strong safety culture? Means which is a safe working environment. Please don't write essays. One or two sentences. Yeah. Feedback, checklist based, structured protocol, communication and feedback, counter checking. Very interesting to see the first word, feedback. Checklists are there, counter checking at each level for register or for patients. For both. Somebody is asking a question for register or patient, for both. Start free, because you may be a patient sometime. So you would want a safe culture. Cross-checking whatever prescribed or written orders twice, protocol, systems improvement, multiple levels of defense, double checking system, healthy workforce, strict protocols, strong leadership, open communication. Fantastic, actually. A lot of very, very interesting, very relevant thoughts. Open communication, teamwork, system level changes, ensure patient cannot be admitted without re-allotting. Okay, I think nice. You're all thinking very well. So that AHRQ came up with a safety, this culture of the safety culture tool to assess any environment, which like a hospital or an acute setting, wherever, to see how strong is a safety culture. Okay, it's available freely. You can actually the PDF you can see. It's quite a long one. So they did this and they put it in a database, and based on the results, they actually started coming up with recommendations. So these are some things which were part of the survey tool. The things that they assess: communication openness. Communication openness is somebody who is not scared to talk about a problem of safety in the ward, in the hospital. Okay. Feedback and communication about error. You're not scared about whether you'll lose your job. You do an error and say this has happened. Okay, that means the culture is a non-threatening culture. Frequency of events reported. People are bold enough to report the events. Handoffs and transitions. How does this happen? When you're finishing a duty, do you hand off well so that the next person taking over has all the details that are needed to run the place smoothly? Okay. So whenever you change your posting, how smooth is the transition? How good is the transition? When you move from, let's say, center to outer or M1 to M2, how is the how is the transition? Management support for patient safety, that is indispensable. We need the support of the management and the leadership. Non-punitive response to error. Non-punitive is error is not punished. On the thinking that to err is human, what should be punished? What should be punished? Non-punitive response to error. That means error should not be punished. What should be punished? Come on, I want to hear the word. Yes, louder. Reckless behavior. Okay. And at-risk behavior should be warned. Reckless behavior should be punished, of course. Okay. Organizational learning, there's continuous improvement based on feedback and number and data. Overall perceptions of patient safety, staffing level, supervisor manager expectations and actions promoting safety, teamwork across units, teamwork within units. All this will give an idea of how safe a unit is. Okay. So this survey, we can actually do a culture. We can do a survey and find out how actually good it is. I think sometime back it was done by the quality management team. Yeah. This is not just wards and acute settings, but even medical office, like a ward office can also, because errors can happen even there. Remember when you said a reply to a patient, errors can happen, isn't it? Give the wrong medical report, inform the wrong person, whatever. So even there, it's important that there is a safety culture. Here is a slightly different a list of things. Work pressure and pay, staff training, office processes and standardization, patient care tracking, follow-up, communication about error, organization learning, all that. So it's just not the wards alone. Even the offices matter in terms of safety culture. So how do we foster a culture of safety? One important thing which is identified is error reporting. The error reporting, we do have system. Has anyone used the ADR form in CMC? Have you seen it? If there's an adverse drug reaction, have you? Sentinel events, anybody has reported? Okay, maybe homework today and you go back, open the internet and find out where there's the ADR form. Okay, so this actually goes back to 1975. Medications error reporting system was actually formulated by some drug companies and I think few hospitals. So they got feedback, they got a good database, and then they worked on to reduce the errors. Sentinel event reporting came in 1996. Both are in the US. Sentinel event is something that should not have happened, leading to death or loss of limb or one of those bad outcomes. Okay, that should be addressed. We have a Sentinel report event system in the hospital. If let's say if you think it has been, you can report it. For example, the thing that we mentioned, hypoglycemia, the first case, that's a sentinel event. Okay, that cannot happen. So we need to learn from that and make appropriate corrections. Now, the whole idea of safety actually it comes from a lot from aviation, industry. Okay, the airlines are supposed to have done quite a bit of safety related work, and a lot of our medical safety stuff, a lot of it is actually from aviation industry. Which is safer, to cross the road in the exit gate here towards Andhra Mess only, that's called. What's it called now? Andhra Mess. To cross the road or to go in a aeroplane to Delhi, which is safer? Which is safer? To cross or to go on a highway from Vellore to Kanchipuram, or going in a aeroplane from I'm talking only about boarding to landing, not the car that goes to airport. Okay, which is safer. Aeroplane is safer. Okay, because of systems that are built in. Of course, when one airplane crashes, it becomes a sensationalized news. Everybody is talking about that for the next 5 years. But how many people die in India per day in a RTA? It's a huge number, actually. I think almost every minute somebody is dying. Okay, I don't remember the exact number, but age 20 to 40, number one cause of death. What's the number one cause of death? Age 20 to 40. This mortality will not come to you. It's road traffic accident. Number two, self-harm, suicide. Then comes all the other stuff, heart attack, cancer, this, that. First is road traffic accidents. It's so unsafe in our roads. It's like, I can rattle off names to you of our faculty and students who have died in the last 10 years, accidents. It's so common, but that doesn't come to you because there's a problem of safety outside. Okay, our roads, because I don't think our traffic and the roadways have learned anything from aviation industry. It is because they have worked on it and made it so safer over the years. So they have this aviation safety reporting system, which is operated by NASA, collects incident reports submitted confidentially so that people are happy to report, otherwise they won't report about aircraft. Suppose if you make a mistake, they report it. So this is indexed and identify information anonymous, analyzed by a group of experts, and information is disseminated through bulletins and monthly safety publications. Now, the role is to hold providers accountable for performance, the role of error reporting systems in hospitals, and to improve patient safety through learning from errors. Now, can you write what do you feel are the barriers to error reporting in a hospital? Suppose if you do an error, what will be the barriers to report that error? You've done an error, you have to report it. Would you think twice? And if you will think twice, what are the reasons? It's very real reasons, isn't it? Fear of consequences, hearing you're incapable, with lack of awareness, fear, ignorance, procedures involved, hurting the coworker, being nice to the coworker, not as written, bad name forever, procedure and aftermath, not recognizing error, punishment. So you see, it's not easy to report errors, isn't it? So all of us do have a responsibility to make the environment more safer to report an error, more safer to communicate, isn't it? It's quite a lot to do with leadership, quite a lot to do with seniors, quite a lot to do with people on higher position within the department, within the institution. But it can start even from junior level. Okay, hopefully we will move towards the right direction. Protecting the person done. These are very true ones. Yeah. But remember, actually, one error, we can actually learn from the errors of somebody else, and that error can be avoided in the future. So, commonly acknowledged barriers of, to error reporting: lack of knowledge, time, fear of reprisal, culture of blame, believe that there was no need to report errors that caused no harm to the patient. Lack of feedback, that is the one major thing, which this is a I think study done in Australia, which came that one of the thing is you report an error, nothing happens. Then like, why bother? So that can be a real reason. So system has to acknowledge the errors and give feedback. Okay, this is how you can avoid it, and this is the system level change that can happen. And this is another data. Close to 97% of error reporting is done by nursing and not by physicians or anybody else. Nurses are the one who report. That's very true even in pharmacy, even in CMC. The error reporting that comes to us is mainly nurses. Okay. I think that's because they have a system of their system is slightly different, and the place there where they work is also slightly different from where we work. We just carry on. Yeah, you don't report, but then the report gets repeated again and again and again. So we can learn from errors. What we need is transparency in the system, that we are open to report an error. We can admit fallibility, that we are all capable of doing mistakes. We are not superhuman people. Okay, we can't remember everything. We can't remember every dose, and we are not people who don't do mistakes. We can admit fallibility, and error reporting helps us learn from errors made by others, which is good. So, which means we may not repeat that error again. And there used to be emphasis on anonymity while error reporting, but there is a limit to it, because we can't really take a corrective action in terms if there is anonymity. Let's say there's an error in my ward. This one patient was given wrong drug. Will that help change the system? It's not going to help, isn't it? So there's a limit to what anonymity can do. And we also have to balance the thing of transparency versus liability. So interestingly, in the US, they had an act, Patient Safety Quality Improvement Act, I think, Safety and Quality Improvement Act in the US, nearly about 25 years back. So this act advocated for creating patient safety organizations. Remember, the health system in the US is mainly a lot of big private groups. So they themselves will not report it, because that will affect, because it's it's a private thing, isn't it? Just imagine the hospital reporting maximum number of errors out of, they're trying to be nice, good, transparent, they're reporting. What will the other people do? Do you really want to go to the hospital which is reporting more? In fact, that's what happens in our states in India. Tamil Nadu will have quite a lot of Tamil Nadu and Kerala, many of the reporting things, because the system is good. So some of these numbers will look higher in the south, whereas some of the states where the reporting is not going to look as if some of these numbers are very less, but actually there's a problem in the system. Okay, reporting is not being done. So what this act, this act said was, they said create this patient safety organizations, which will collect data from different organizations, private organizations. They will collate it and report it and say, these are the incidents that are happening more. And they give recommendations. So there is anonymity. Nobody is worried that at the same time, we are actually getting data from all the organizations. We all follow me. Yeah. So nobody is blamed, but we have the data and we can act on it. Okay, these are the common medical errors. We can do something to avoid it in the future. Apart from error reporting systems, with the morbidity and the mortality conference, death audit, you all been part of it. So that's a mortality audit that we do. It's actually started with nearly about 125 years back. The one doctor called Dr. Ernest Codman is a surgeon. He actually gave a card before he started surgery. Everything was noted down, and then periodically, I think once a year, they went through all the outcomes of these cards to learn learn from the mortality. If something went wrong, they went and said, okay, why did it go wrong? That's the earliest, precursor to this, what we have as death audit. Then another thing that came was an anesthesia, which was anesthesia mortality committee, that sort of evolved into the modern day, death audits that we have. Quite a lot of educational value in general. Studies done among students, PG students, and other trainees. Thing is, they quite a lot of learning value in these death audits. Do you all agree? When you do a death audit, you learn quite a bit, isn't it? We don't want to do the mistake again. So again, the principles apply. We should not be pointing fingers, finding out who did what. Of course, we will know whether it's reckless behavior or not. But in general, error should not be as to finding on who it is and sort of creating a bad name for them. That should not be the intent. Intent is, can we learn from this errors and change system level changes so that we can avoid this in the future. Okay. But the problem is underreporting. Very often, many death audits will come to you because MRD gives it. If you do a morbidity audit, many things may not really come out. Okay. I think in our system it's quite okay. I think we do get all the death audits. It can actually sometimes not come. I know sometimes you realize in a month there may be 12 deaths, only 9 deaths will come to your table. We need to be aware of the fact that we need to look at all of them to make sure we learn from the mistakes. There are people who have tried various methods to avoid this, pitfall. They've had nurse reviewers who are different from the team which is treating, for them to go through and and for them to collect the data. That is one. Computerized hospital diagnosis coding has been tried, for them to pick up, all the underreported ones. There are people who have tried. These are studies. Follow up with patients through letters and phone calls. Have been done for them to learn, from the mistakes. Okay. One question for all of you. How can our mortality meetings be made more useful? All of you have been in audit, death audit. We all have, isn't it? Every unit has. Yeah. You've actually gone through the chart. How can we make it better? Speak properly, less confrontational. Come on. Learning points, protocols creation. Avoid blame game. Identify the type of error. Cross-check chart in audit. Filing death audit forms. Okay, I think I'll move on. Compile errors and re-audit. So the people have tried various methods. One method that's been tried is using the same S bar that we use for communication. You're all aware of S bar now. Now that you attend communication workshop, I hope most of you are aware of S bar. How many of you use it? Use S bar, consciously when you speak to somebody in the phone. Show of hands. Does it come to your mind that okay, this is a nice? Are you aware? Interns, are you aware of S bar? SPAR? No. Okay. That's something maybe we should do a workshop for the patients also. Sorry, for the interns also. Okay, so situation, like just like how we do for communication, we can do for death audit to see what happened. So look at the situation, admitting, diagnosis, operative procedure, and adverse outcome. Look at the background, patient history, procedural detail. This is what actually mostly happens. This makes it a bit more structured, that we know we are not looking at a lot of other things, but we are quite focused. Hospital course, recognition and management of complication, assessment, do an error analysis and a root cause analysis. That is, I won't cover the root cause analysis in this. That's a tool to assess events. What can we learn from error? There's a very nice structured way of doing it. That's just one root cause analysis, just one way. There are other methods also. And then finally, come up with a recommendation, areas for improvement and learning points. I think in medicine for mostly we follow this. I think most of the units also usually follow this of having a asking the question, what went wrong? Is it possible that this complication could be prevented? Okay. So we should not try to point fingers there. But I think if there is reckless behavior, that's proof that there is some reckless behavior, then that should be dealt separately. But the mortality audit is mainly to look at errors which can be prevented by change in systems. Then, of course, we need to, whatever findings we get from error reporting, mortality, it's good to spread the lessons that we learn. People have tried in the aviation industry, they do these monthly bulletins, discussion of case reports. I think this is something which we can learn. Like even in pharmacy, we actually send out the list of errors, but I don't think we have a system to let people know of the common errors. This is something that I think it can be worked on so that people will know, well, this is an error which can happen. I'll be more alert. There are some hospitals where safety rounds. Once a month, the top leadership and people involved in safety go around talking to people. How is the safety? Do you feel safe to report? Do you think anything is unsafe, and so on? That sort of creates some sort of momentum. When people say people do take safety while seriously. I can give feedback. For example, let's say if you think you're concerned about a defibrillator which is not working, okay, is that a safety thing? It is, isn't it? If defibrillator is not working and if there's a cardiac arrest, and if you look the other way, when you need the defibrillator, there'll be no defibrillator, isn't it? We need to ask, is there any problem? Okay, let's work on it, and that has to be sorted immediately. I think that may be one of my last slides. Implementation based on error reporting, based on all that we learn, event analysis, which I'm not going into, lessons learned should be implemented. That is another field altogether, implementation science and so on. Hopefully we'll do it in another session. I think leadership commitment is so important here. The lessons that we learn has to be implemented across unit, departments, institution-wise, without which all our event reporting, learning is of no use, because system will just remain the same. Hopefully you'll have learned something about safety and principles in analyzing, and wherever you are as consultants, you may become hospital directors, or wherever you're going to work, bond, non-bond teachers. Hopefully you'll look at your system with a safety lens and say, is my workplace safe, and can I do changes in the system to make it more safer? It's not easy. It requires quite a lot of especially teamwork, working across units with the management to make sure our department is safe. But then at the at the grassroots level, if you don't give feedback, there's no way the leaders will know. There's no way the head of the department will know, okay, this is a problem. So you should feel free and open and bold enough to talk about errors that can happen, because by saying that you're avoiding an error in the future. I'll stop there. Any questions or any comments? Yes, Dr. Samya. Yeah, monthly bulletins, is a good idea. Um, it should be not just in pharmacy, even within departments. We can actually work on it, and it can be sent by email. Only problem is if we give too much data, people just scroll it and ignore it. It'll be just another data which just comes and you ignore it. It should be done in such a way that people will actually read and learn. So it should be done. Correct. Very nice to know that you were reading it. So I'll give that feedback to the team. So that's actually quite a lengthy journal, which is with multiple articles and things like that. It can be actually condensed into a monthly bulletin of lessons from error reporting, adverse events, etc. Any other comments, questions? Come on, you can start, practicing boldness from now. There are actually, I think one problem is in a safe culture, there'll be people will be free to communicate. There are clear guidelines as to how you should communicate boldly without actually hesitating, addressing people like whatever, looking at the eyes, talking to them without feeling any sort of inhibition to say, oh, what will they think? um, there should be so-called psychological safety that you are free to report a problem. That is in sort of an indicator as to how open our culture is for a safe environment. So if we don't speak, we'll have to practice. So that's why we have communication workshop. And PG time is a good time to practice. That's it. This side, nobody. Okay, we can have a chat over the if there's coffee. Thank you.